Thank you so much for your introduction, Professor Satapathy. And today I will comment on different points, all related to ACLF, acute-on-chronic liver failure. These points include terminology, epidemiology, pathophysiology, management, and I will have some words on the research agenda, which is very busy, as you will see. First, different consortia develop different definitions of ACLF, and I think it is important to comment on this difference. A definition has been developed by the European EASL-CLIF Consortium, another one by the North American NACSELD Consortium, another one by the APASL Asian Consortium. I will not comment on the Chinese definition of ACLF provided by the Koch Consortium because diagnostic criteria of the Chinese definition are very, very close to the European criteria. Therefore, I will concentrate on these three different definitions. Before commenting on definition of ACLF, I would like to define some terms which will be used during my talk. The term acutely decompensated cirrhosis refers to recent ascites, hepatic encephalopathy, GI hemorrhage, or any combination of these disorders in patients with cirrhosis. Clinically apparent precipitant of acute decompensation of cirrhosis include extrahepatic precipitants, such as acute infection or GI hemorrhage, but also intrahepatic precipitants, such as alcohol-related hepatitis. A full list of potential precipitants of ACLF is provided in the recently published European Clinical Practice Guidelines on ACLF. The term short-term mortality rate refers to the percentage of patients who died within 28 days after enrollment without having received liver transplantation. The EASL-CLIF Consortium conducted the Canonic study, which was a prospective European agnostic observational study designed to determine criteria for ACLF in patients non-electively admitted for acutely decompensated cirrhosis with or without prior decompensation, with or without ongoing clinically apparent precipitant. Importantly, the protocol pre-specified the diagnostic criteria of organ failure for each of 6 major organ systems, which will be described in the next slide. The study protocol also pre-specified our assumption that ACLF should be associated with short-term mortality rate of 15% or more. Data were collected on granular electronic CRF, continuously monitored by skilled data managers, which is a guarantee for the quality of collected data. A total of 1,343 patients were enrolled in 2011 and analyzed between the end of 2011 and the beginning of 2012. This slide shows the CLIF-C organ failure scoring system used by the European investigators. As you can see, this scoring system considers 6 organ systems: liver, kidney, brain, coagulation, circulation, respiration. Each organ system receives a score ranging from 1 point less severe to 3 points very severe. And it is very important to emphasize that the cutoffs on this scale have been defined not by expert opinion, but are based on the hazard ratio for death by 28 days we computed when the scoring system was designed. The light gray zone indicates the definition for organ dysfunction. The dark gray zone indicates the definition for organ failure. For example, liver failure was defined by a bilirubin of 12 or more. Kidney failure was defined by a creatinine of 2 or more or the use of renal replacement therapy. Brain failure was defined by West Haven grade 3 or 4. Coagulation failure was defined by INR of 2.5 or more. Circulatory failure was defined by the use of vasopressors, and respiratory failure was defined by either a PaO2 to FiO2 of 200 or less, or a PaO2 to FiO2, SpO2 to FiO2 less of 214 or less. This slide is very important because it gives you the information used to define ACLF in the Canonic study. As you can see, this slide shows the prevalence, short-term mortality, and the assigned grade of ACLF among the 7 distinct groups which have been identified in the Canonic study. As you can see, 68% of the patients included in the cohort didn't have organ failure and had a very low mortality of 4.5%. 10% of patients had a single non-kidney organ failure without kidney dysfunction or brain dysfunction, and their mortality rate was only 6%. These two groups were merged in a single group labeled absence of ACLF because of the low mortality rate. You can see that 7% of the patients had a single kidney failure with a mortality rate of 19%. 4% of the patients had a single non-kidney organ failure with kidney dysfunction or brain dysfunction, and these patients had a mortality rate of 28%. These two groups were merged in the single one labeled ACLF1, ACLF because the mortality was more than 15%, and 1 because they were characterized by the existence or the presence of only one organ failure. 7.5% of patients had 2 organ failure with a mortality of 32%, and these patients were labeled ACLF2. 2% of patients had 3 organ failure and a mortality rate of 68%. 1.5% of patients had 4 to 6 organ failure and had a high mortality of 89%. And these two groups were merged in a single label of ACLF3. Therefore, you have here the definition, the evidence-based definition of ACLF, which has been defined thanks to the results of the Canonic study. Another point which is very important is summarized in this slide. We also run a large observational study in 1,274 patients admitted to the hospital for acutely decompensated cirrhosis in Latin America. This study is called ACLARA. In this study, we investigated factors that were associated with short-term mortality with the use of multivariable analysis. And here I show the association of markers of organ failure with short-term mortality as identified in the ACLARA study. As you can see, the markers of organ function which were independently associated with higher short-term mortality included decreasing mean arterial pressure, decreasing SpO2 to FiO2 ratio, decreasing albumin, increasing creatinine, and increasing INR. These results are very important because for the first time they demonstrate that it is very important to consider at least these five organ systems to assess the prognosis of patients who are admitted to the hospital for acutely decompensated cirrhosis. NACSELD definition was based on the analysis of a database of prospectively collected data on a red cap, which is a tool not so bad. Data from 2,675 patients were collected, and the inclusion criteria, as you can see, were very close to the European criteria because patients were non-electively admitted for acutely decompensated cirrhosis with or without prior decompensation, with or without ongoing clinically apparent precipitants. The study protocol pre-specified the criteria of organ failure for each of four organ systems: kidney, brain, circulation, respiration, and I will describe this criteria in the next slide. It is important to note that the NACSELD didn't consider liver failure and coagulation failure to define ACLF. These are the diagnostic criteria for organ failure in the NACSELD consortium. Kidney failure was defined by the need for renal replacement therapy. Brain failure was defined by hepatic encephalopathy grade 3 or 4 West Haven. Circulatory failure was defined by the presence of shock, which is refractory to fluid resuscitation requiring vasopressors. Respiratory failure was defined by the need for bilevel positive airway pressure or mechanical ventilation. As you can see, the NACSELD investigators were interested in very severe patients admitted to the ICU. This slide shows the probability of dying by 30 days among patients with a NACSELD definition according to the number of organ failure. As you can see, the probability of dying rose from 4% in patients with no organ failure to 77% among patients with 4 organ failure. And the NACSELD investigators decided to define ACLF when there were 2 organ failure or more. Let's see now the APASL definition of ACLF, which is based on the opinion of APASL experts who analyze a database. I must say that the data collection and the management of the data collection was relatively opaque, and I think that these investigators should clarify how data were collected. In any case, this definition includes patients with compensated cirrhosis or non-cirrhotic chronic liver disease who had the first episode of acute liver deterioration due to an acute insult directed to the liver. This definition of ACLF is the following: acute hepatic insult manifesting as jaundice, bilirubin of 5 milligram or more, and coagulopathy, INR of 1.5 or more, complicated within 4 weeks by clinical ascites, hepatic encephalopathy, or both. This definition excludes extrahepatic precipitants and also exclude organ failure involving kidney, respiration, circulation. So to me, in summary, for patients hospitalized with acutely decompensated cirrhosis, the EASL-CLIF definition of ACLF should be used because it is an evidence-based definition which considers the function of 6 major organ systems and covers a large spectrum of severity. The NACSELD definition of ACLF mainly applies to ICU patients with acutely decompensated cirrhosis, and the APASL definition applies to patients who are different from those considered by the European and American definitions. So the question is, can we reconcile the definitions? The answer is maybe. Recently, Kulkarni and Sarin published in JHEP an hypothesis which was the following. The patients captured by the APASL ACLF definition, in fact, are patients at the early stage of the trajectory. Patients captured by the EASL-CLIF ACLF are patients who are at the intermediate stage of the trajectory. And patients captured by the NACSELD ACLF are at the late stage of the trajectory. This hypothesis is very interesting, but should be confirmed by large international prospective longitudinal studies. And I hope that we will be able to gather all the international societies and consortia to run this kind of studies, which would be very important to harmonize the diagnostic criteria. Epidemiology, the global burden of ACLF has been investigated in a recently published meta-analysis of 30 cohorts using EASL-CLIF criteria in around 190,000 patients admitted to the hospital for decompensated cirrhosis. 5 in 10 patients had alcohol-related cirrhosis. 3 in 10 patients had a cirrhosis of viral cause. 4 in 10 patients had ACLF, and 6 in 10 patients with ACLF died by 90 days versus only 1 in 10 patients among those without ACLF. Therefore, this study clearly shows that the global burden of ACLF is high. However, this study has several limitations. In particular, it used both prospective and retrospective studies, and no information was provided on a burden of MASLD and the impact of new therapies for MASLD on the burden of ACLF. And therefore, I think that it would be very important to run large national and international granular prospective epidemiological studies in the future, in particular for including patients with MASLD. Pathophysiology. In the Canonic study, we investigated systemic inflammation by assessing in blood leukocyte count and the levels of CRP and cytokines. And this analysis led us to conclude that systemic inflammation exists in any form of acutely decompensated cirrhosis, is more intense with ACLF than without ACLF, is more intense in ACLF3 than ACLF1 or 2, and is less intense when ACLF improves. These findings led us to hypothesize that intense systemic inflammation is a major driver of ACLF development. This cartoon summarizes the current model for ACLF pathophysiology. Precipitants such as infection, acute liver injury are associated with the release of pumps and dams, which induce intense systemic inflammation and systemic oxidative stress. Please note that also consider that the translocation of pumps from the gut lumen to the systemic circulation might explain the development of intense systemic inflammation among patients who develop ACLF without any clinically apparent precipitant, which represent approximately 20 to 30% of patients who present with ACLF. But this hypothesis, in fact, should be confirmed by large dedicated studies. As you can see, systemic inflammation can induce organ failures through three different mechanisms, which are not mutually exclusive. First, on the left, cytokines, PAMs, accentuate nitric oxide-mediated splenic vasodilation, which results in a decrease in effective arterial blood volume, which in turn may result in renal hypoperfusion and subsequent kidney injury. The second mechanism is the activation by cytokines of immune cells to cause immune-mediated tissue damage. In the third mechanism, systemic inflammation induces hypometabolism in peripheral organs with decreased mitochondrial oxygen consumption and decrease in ATP synthesis, which may contribute to the development of organ failure. In animal models of sepsis, it has been shown that cytokines PAMs activate some areas in the brainstem, which in turn orchestrate hypometabolism in peripheral organs. Therefore, we suggest that this mechanism may explain also peripheral hypometabolism, which is observed in patients with ACLF and also contribute to the development of organ failure. This cartoon is probably incomplete because it doesn't consider the existence of immune deficiency, which develop in parallel to systemic inflammation, and immune deficiency, which affect almost every immune cell of the innate and adaptive class, is a very important feature which can promote infection and therefore promote the development of ACLF. Management. Medical management, is based on two principles. First, diagnose acute precipitants and treat them urgently. The second principle is to provide supportive therapy in the ICU or intermediate care unit. And the objective on medical treatment is to bridge patient to liver transplantation. I will not go into detail of the medical treatment, but I will address only some points. First, the treatment of precipitants, in particular acute infection and alcohol-related hepatitis, which are very common precipitants among European and American patients, and also more and more common in Asia, including India. As you know, the use of empiric broad-spectrum antibiotics is recommended to treat infection which trigger ACLF. However, this strategy may be ineffective because the empiric broad-spectrum antibiotic may not cover multi-drug resistant bacteria. And the question is treatment failure an important feature? The answer is yes. This has been nicely demonstrated by Trebica and Fernandez, who analyzed the large series of patients included in the PREDICT study. They looked at patients with ACLF in whom bacterial infection was the precipitant, and they looked at the quality of the empiric broad-spectrum antibiotics which were used initially to treat these patients, and they classified the antibiotics into adequate and inadequate, and they looked at the impact of the adequate and inadequate therapies on the cumulative incidence of mortality, which is shown here. As you can see, the cumulative incidence of death was significantly higher among those patients who receive inadequate antibiotic therapy versus the cumulative incidence of patients of death who receive initial adequate antibiotic therapy. Therefore, it is very important to consider this point. And can we anticipate the failure of empiric broad-spectrum antibiotics? In fact, it is a very difficult question, probably the toughest question to address in the future. And this is why in the EASL Clinical Practice Guidelines, the recommendation by the expert was very humble. They said that patients with ACLF and suspicion of bacterial infection should receive broad-spectrum empirical antibiotic therapy according to local epidemiology as soon as possible. It means that, in fact, the attending physician should be aware of the local epidemiology, and therefore they should discuss as often as possible with the bacteriologist, the local bacteriologist. Another interesting point is the treatment of alcohol-related hepatitis with the use of corticosteroids. And Thomas Sustry and colleagues in Brussels looked at the percentage of patients who responded to corticosteroids, and they nicely showed that patients who didn't have ACLF had an excellent response to corticosteroids. And in contrast, at the opposite, patients who had the ACLF grade 3 has a very low response to corticosteroids, while patients with grade 1 or grade 2 and an intermediate response. These findings have been confirmed in several other studies and led the European experts to recommend that corticosteroids should not be used in patients with ACLF3 caused by alcohol-related hepatitis. They also recommended that corticosteroids should not be used in patients with uncontrolled bacterial infection, which is an important recommendation because very often patients with severe alcohol-related hepatitis present with concomitant bacterial infection. Supportive therapies. Should we use artificial or bioartificial extracorporeal liver support or plasma exchange in patients with ACLF? The European expert said no. This device should not be used outside investigative trials, and I think it is very important. We will have the results of large trial of plasma exchange in ACLF, which is ongoing right now under the umbrella of EASL-CLIF, and the preliminary results are extremely encouraging. But let's wait for the publication of the results. Another interesting point is the treatment of hepatorenal AKI, which is a form of ACLF, the treatment with terlipressin. Piano and colleagues have investigated the relationship of some factors with the expected probability of response to terlipressin. In particular, they investigated the impact of baseline serum creatinine and the baseline grade of ACLF 1 to 3 on admission. As you can see, the higher serum creatinine, the worse the response to terlipressin, which is not a surprise. But another interesting finding of this study was that, for example, for patients with baseline serum creatinine of 3, the probability of response to terlipressin was 75% among patients with grade 1 ACLF, and was only 35% among patients with grade 3 ACLF. And the percentage of responders was intermediate for those who were ACLF grade 2 at baseline. The take-home lesson of these results is that the sooner the better. Patients should receive terlipressin very early to treat hepatorenal AKI, but also very early in the course of ACLF if we want to have an effective response to treatment. The European expert also gave recommendations for the site of admission. The patients should be admitted to the ICU in case of need for organ support, vasopressors, mechanical ventilation, or renal replacement therapy. The other indication for the ICU included massive bleeding, grade 3-4 hepatic encephalopathy requiring airway protection, septic shock, and also it is important to note that the time to admission is a very important point. Patients should be admitted to the ICU within the first 6 hours after the diagnosis of ACLF. Patients should be admitted to the intermediate care in case of variceal bleeding, but also the other indication include grade 2 or 3 hepatic encephalopathy and sepsis with hepatorenal AKI or patients with liver or coagulation failures. These are general recommendations, of course. An important recommendation provided in this guideline is the following. The risk of death should be evaluated 3 to 7 days after starting full organ support and not an admission. In other words, any patient with ACLF should be intensively, actively treated in the appropriate site of admission, and the final assessment should be done during the first week after active treatment. An interesting aspect of ACLF is the use of liver transplantation. Recently, Thierry Gusteau and Javier Fernandez were interested in the patients with ACLF 2 or 3 who were enrolled in the Canonic study. And they looked at 6 months survival among patients who received liver transplantation during the first 28 days versus those who didn't receive early liver transplantation. As you can see, the probability of survival was excellent among patients who received early liver transplantation, 81%, and was extremely low, 10% among those who didn't receive liver transplant. It is important to note that the time window for liver transplantation is very narrow because, as you can see, at 28 days, the probability of survival was only 23%. Therefore, you have to make the decision during the first 28 days. It is a very important point. These results have been confirmed in several retrospective studies published in Europe and in the US. And now we are running a large prospective global study of liver transplantation in ACLF3 to refine the results and define futility criteria for ACLF for transplantation in the context of ACLF. Sorry. So the European experts recommend the following points. First, an early assessment for liver transplantation should be proposed for all patients with severe ACLF, ACLF 2 or 3. Second, defining criteria for futile liver transplantation in patients with ACLF3 is an urgent medical need, and we hope to address this urgent medical need through the current study, which is called CHANCE. I would like to finish my talk with some words on the research agenda, which is very busy. Therefore, I will give only one example. This cartoon is a cartoon used in the EASL Clinical Practice Guideline. And on the left, you have the different organ systems which are considered for defining ACLF, the six organ systems. And on the right, you have all the other organs systems which are altered in the context of acutely decompensated cirrhosis, including cirrhotic cardiomyopathy. The immune system has features of immune deficiency and features of systemic inflammation. Adrenal gland you have adrenal insufficiency. In the gut, there is a barrier dysfunction and bacterial translocation, which are very important features of decompensated cirrhosis. In the muscle, we have sarcopenia, phrygmia. Therefore, in the future, we should investigate whether we should include this different organ system in our assessment of the severity of patients, and therefore enrich our current assessment of organ system with this additional organ system. So in conclusion, to me, the European definition of ACLF is an evidence-based and widely used among patients with acutely decompensated cirrhosis. ACLF is the most severe form of acutely decompensated cirrhosis. Systemic inflammation is the key pathogenic mechanism. Medical management should be urgently started against precipitant and failing organs. Early liver transplantation for ACLF 2 or 3 seems effective but limited due to narrow time and in some countries due to organ shortage. And the research agenda is very busy. Thank you again for the invitation and thank you for your attention.